Hello everyone, I'm Craig Clifford, medical oncologist in Malvern, Pennsylvania, and today we're going to be discussing some interesting topics in canine lymphoma. Lymphoma, certainly for you in general practice or in specialty practice, we know it's one of the most common cancers that we see. It's probably the most common hematologic malignancy that we see. And we tend to break it down into different areas. The most common form, of course, is the generalized or multicentric form. And these are the dogs that are coming in with the enlarged lymph nodes. And that represents probably somewhere close to 85% of all of the lymphomas. The rest are broken down to gastrointestinal, cutaneous, mediastinal, or what we call extranodal. So it may be central nervous system, bone, something odd like that. But those are the most common forms, with multicentric or generalized nodal being the most common form. So in our multicentric form, this is the one where the case comes in to see you for a lump. It's on your schedule. Owner says the dog's running around like crazy, really happy, but while they were petting them, they felt something. As soon as you do your physical exam on it, you realize the lump the owner is talking about is actually a lymph node. We know that the vast majority of these dogs feel fine, so they're considered what we call a substage A. That represents probably about 85% of them. The other 15% are what we call substage B. So these are the dogs that come in ill. It could be weight loss, vomiting, diarrhea. They may have a fever, or they're drinking and urinating a lot. And that occurs in about 15% of the cases because they're hypercalcemic. And that's more common when it occurs in the chest. So when it happens in the mediastinum, about 40% of those cases end up being hypercalcemic. And the one thing we certainly know is dogs that present substage A, I feel fine, versus substage B, the sick dogs. The substage A's do tremendously better. It is one of the most powerful prognostic indicators for this cancer. So in obtaining the diagnosis of lymphoma, certainly a dog coming with enlarged lymph nodes lends credence to it, but a definitive diagnosis generally is going to be through cytology. And this is certainly an easy one where you can aspirate the node yourself, take one of the slides, look at it under the microscope. Basically, the most common form of lymphoma we call large cell lymphoma, and it's a pretty easy diagnosis. A large lymphocyte is usually about the size of a neutrophil, and its nucleus is about the size of a red blood cell. So that kind of gives you an idea when you look at it. So to me, if I'm trying to determine if it's lymphoma, the first thing I want to see is what are the size of the lymphocytes? Are these all small lymphocytes, or am I seeing a mixture, which means it could be a reactive node, or is it just completely filled with large lymphocytes? When I see something like that, that is an easy diagnosis of lymphoma. Traditionally, we still send these off for cytology to a clinical pathologist. That way we can at least have a definitive diagnosis. If we have a case where cytology was inconclusive, or we didn't have enough cells, or the cells were lysed, well, then we can either consider re-aspirating it, or we may biopsy. Biopsy is probably more beneficial if we're thinking the grand scheme of veterinary medicine, because if we take a page from physician-based oncology, there are so many different histologic subtypes of lymphoma that probably occur in dogs, but we don't know because we haven't done enough biopsies. So although biopsy is challenging due to the anesthesia or sedation that's required, the morbidity of it, and the cost, ideally biopsy is where we're going to learn the most about lymphoma if we're looking to move forward as a field. So once we've gotten our diagnosis of lymphoma, the next step is staging. And as we've discussed, staging is simply where is it within the body and how healthy is the patient. So traditionally, much of the staging I recommend being done with the primary care before the case even comes in to see me. That way you've learned more about the case and can provide the owner with more information before they even come in to see the specialist. So I certainly recommend routine blood work, a CBC and a chemistry panel. On the CBC, we're looking to see are there any blood dyscrasias to make us think it could be in the bone marrow, such as anemia, thrombocytopenia, or leukopenia. Or do we actually see cancer lymphocytes are floating around in the blood? Our chemistry panel, we're looking to make sure, first, are they healthy? But do we see there may be hepatic involvement, or are they hypercalcemic? Having a high calcium at diagnosis is considered a poor prognostic factor. Additional staging, I think, is very much oncologist dependent. I'm somewhat of a minimalist, but many oncologists will do chest radiographs, and we're looking for a mediastinal mass because we know that's considered a poor prognostic indicator. Abdominal ultrasound, I think, has become somewhat controversial because of the fact that basically we're looking at the liver and spleen as our main organs to see if it's there. And in those cases, many studies have since shown that dogs that have it in their liver and spleen may do similar to dogs that don't have it. So to me, unless the patient's very ill and I'm trying to find out a reason for it, I don't jump to doing ultrasound on all the cases because it doesn't necessarily change their prognosis, nor does it change how I'm going to treat them. But is there anything wrong in doing it as a diagnostic? Not at all. It does provide us with more information. Back when I was being trained at the University of Pennsylvania, we used to do bone marrow aspirates on all the cases. We've kind of moved away from there. The main reason for the bone marrow aspirate was to look to see, is it in the bone marrow? That's considered what we call a stage 5, and generally those patients have a poor prognosis. We've moved away from it because it is a challenging test, and for the vast majority of cases, it's a low yield. And oftentimes, many oncologists, we tend to think that if it is in their marrow, we may be able to pick up some cytopenias on the blood work to give us an indication. So bone marrow aspirate has kind of fallen out of favor with most oncologists. So now that we've done the different staging diagnostics, it allows us to put them into a stage of disease. Dogs and people are staged 1 through 5. So a stage 1 would be only one lymph node or one organ involved. A stage 2 would be multiple nodes, but say regionally, our neck, the shoulder, the groin, etc. Stage 3 is what I call the textbook dog. That's multiple lymph nodes affected at the same time. A stage 4 is a dog that has it in their liver and spleen. And stage 5, it's in the bone marrow or an atypical area. It's in the eyes, it's in the central nervous system, something that is abnormal. We call that a stage 5. Many of the studies have shown certainly stage 5 carries a poor prognosis, but stage 3 and 4 are somewhat similar, and oftentimes their survival times tend to overlap. Hence why I don't necessarily recommend ultrasound and aspirates of the liver and spleen in dogs. We then, of course, put them into a substage. And as mentioned, that happy, healthy golden that's running around the exam room where the owner is shocked to hear they have cancer, that's a substage A. Those dogs are generally going to do better versus the dog that comes in with 3-pound weight loss, can't intake any food. That's a substage B, which carries a poor prognosis. So the other important part of the staging is from the staging diagnostics, we can then look at some of the various prognostic factors for lymphoma. There are many of them. We're not going to go through all of them, but we're going to touch upon some of the more important ones. As mentioned, a stage 5 carries a poor prognosis versus an earlier stage. A substage A does better than a substage B. Immunophenotype, which we're going to spend some time talking about, large cell lymphoma, we break into 2 groups. One of which is called B cell. I tend to say to owners, B is in better. The other is T cell. T is in tougher to treat. The literature suggests that T cell is a poor prognosis. And then the anatomic form. So where is it occurring? Dogs that have it in their mediastinum, gastrointestinal tract, within only the liver, or those that have it on their skin generally carry a poor prognosis. And it turns out that those anatomic locations are generally going to be a T cell lymphoma. Again, T cell being tougher to treat, carrying a tougher prognosis. Other prognostic factors that play a role is the use of prednisone. Patients that have been on prednisone, generally prior to at least 2 weeks or longer, it may affect their prognosis if we decide to treat them. Why is that? Well, if prednisone is used all by itself, it sets up multi-drug resistance. So the efficacy of the chemo drugs that we would normally use in what we call a CHOP protocol will not be as good if they've been on prednisone. So that's one of the challenges. Now, are there time periods that we would start them on pred? If I can't get the case in right away and the dog is sick, well, then certainly we may put them on prednisone for a couple of days. But what we don't want is the patient to be on pred for a prolonged period of time. If we're doing biopsy, the histologic grade is important. Most large cell lymphomas are deemed high grade aggressive. But there is a subset of lymphomas that are called low-grade or indolent. Their history is very, very different. Instead of the case that we're used to where the nodes are getting bigger day after day, these cases, they've had enlarged lymph nodes for months that sometimes seem to wax and wane in size. And these indolents, many of which we actually don't treat. We simply monitor them. So a low-grade or indolent tumor carries a better prognosis. Hypercalcemia is considered a negative indicator, and that's often seen for mediastinal lymphoma, and it's often seen with T cell. Some studies have shown anemia or thrombocytopenia may be associated with a poor prognosis. And then there was an interesting study from North Carolina State that found that dogs that had hematologic toxicity, meaning we gave them chemotherapy, white cells dropped very low and they became febrile, had to be treated for it supportively, they actually did better than patients that didn't. And it kind of makes sense if you think about it, because if we're doing that to the immune system, think about what we're doing to the cancer. So patients that ended up having toxicity with their bone marrow ended up doing better than dogs that did not. And these are some of the prognostic factors. Clearly, there's another 20 or 30 that are listed, but these are probably some of the more common ones to keep in mind as you move forward with a patient with lymphoma. So if we've done our staging and we've diagnosed lymphoma, what's next? The next thing that most oncologists will recommend, and again, this is something I offer to my primary care vets to do because it helps me in having the test done before I even see the owner, and that's the use of phenotyping. So what do we mean by that? Well, traditionally, large cell lymphoma is broken into two subgroups. We tend to say about 2/3 of the dogs will be B cell, which carries a better prognosis, and 1/3 of the dogs will be T cell. B cell is associated with a better response rate, a longer duration of response with chemotherapy, and they actually live longer. We often know that now there's been enough testing that's been done that there are certain breeds that are more likely to be B cell versus T cell. In regards to B cell, Cocker Spaniels, King Charles Cavalier, and Dobermans have a higher chance of being a B cell lymphoma than a T cell lymphoma. The second form or subtype that we talk about is T cell. We know it represents about 1/3 of the dogs with lymphoma. And T cell tends to be very much anatomically oriented, meaning the gastrointestinal tract, cutaneous lymphoma, pure hepatic, or mediastinal are more likely to be T cell. It can still occur in nodal lymphoma, but not quite as common. So when we look at T cell, if we're talking, say, nodal lymphoma, we know that in general, the response for them is lower, and the duration of response is certainly much lower than that of a B cell. And we tend to say with a standard CHOP protocol, which is what we utilize for our dogs with lymphoma, a T cell probably is about 6 months. We also know that being site-specific, the survival is very different. Gastrointestinal lymphoma in dogs carries a very, very poor prognosis. Some of the studies have shown survival times of less than 20 days, even with therapy. Pure hepatic generally is less than 80 days as far as an overall survival. And cutaneous lymphoma, we can have responses, and we have about an 80% chance of response, but they generally only respond for several months, and then it comes roaring back again. So without question, we know that T cells are more challenging to treat. So now that we understand the importance of phenotyping, how do we determine the phenotype? So the gold standard, of course, is still considered a biopsy and then applying immunohistochemistry to it to determine if it is a B or T. There are other tests that are out there. Some of the ones that you'll come across is a PCR-based test. And we all know PCR stands for polymerase chain reaction. And basically what it does is it makes many copies of a particular gene. When we talk about it with lymphoma, we call it PAR, which stands for PCR for antigen receptor rearrangement. And basically what they're doing is they are looking at the immunoglobulin gene, which would be for B cell, and then the T cell receptor for T cell. The challenge with PAR, though, is that it's not really designed to be a phenotyping test. Where PAR really plays more of a role is to say, do you have lymphoma? Because what PAR looks at is it looks for clones. So the best example I would say is if I took my lymph node out and we looked at every lymphocyte within my lymph node, genetically each one is different than the one next to it. Just like everybody out there in the audience is different than the person next to you. If you have a cancer lymph node, it's one cell that clones itself over and over. So if you take out the lymph node from a patient with cancer, all of the cells are clones of one another. So what PAR looks for is, do you have clones? It is designed to look at B and T, but most pathologists feel it's not a good phenotyping test. It's better as a test when you have a patient that comes in, you aspirate the nodes, and the pathologist says, I don't know, it might be lymphoma or it might not. That is a perfect time period to run PAR, because if it ends up being that it's clonal, you know you have lymphoma, and then you can move forward. The other way we can determine phenotype for canine lymphoma is through flow cytometry. So flow is probably the most commonly used, at least by oncologists, and you need to have live cells for it, so it's a little bit different than, say, PAR, which can be a stained slide we can use for it. Flow cytometry, we need live cells, and basically what we're doing is we're applying monoclonal antibodies with fluorescent markers on them to a sample. And what we're able to do is look at a large number of cells. We can determine if there's atypical cells that are present, and then based upon their surface markers, we're able to say, is it a B or T? So it allows us to categorize and prognosticate. Because the beauty of flow is, since you're applying monoclonal antibodies, you can have a panel of antibodies that can look at many different things that play a role in their prognosis. The challenge, though, is that the way it works is you have to aspirate the node. It's put in saline. Some labs like serum with it, some do not, and then it's sent off. So as you can imagine, if it's live cells, we have to send it overnight to the lab. Probably the most commonly used lab is Colorado State. Antech and IDEX often will send to them. But we get the result back in a week. So where it's challenging is I'm a lucky Saturday oncologist, and there isn't anyone who's delivering or taking things on Sunday. So for me to use flow, I have to put the sample in the fridge over the weekend and then send it out. So one of the only challenges is, being live cells, you need to make sure you send it during the week. They do accept cases on Saturdays, but if it's something you see over the weekend, you may want to look at another type of mechanism to determine the phenotype. So the final way we can determine phenotyping would be through immunocytochemistry. So basically all we're doing is applying the same monoclonal antibodies, but instead of being applied to live cells or being applied to a histopath sample, we're applying them to cytology. So certainly it only really gives us the ability to look at one or two markers. So we're just looking to see if it's B or T. We can't really run a panel because we only send them usually a few slides. But in cases where, say, I work on the weekend and I'm going to send something on a Saturday, I'll simply do immunocytochemistry, get my results back within less than a week, and then I can go through that with the owner. So one of the questions I get asked is, what is the best method for determining phenotype? So there is a paper that came out several years ago out of North Carolina State that looked at the gold standard being immunohistochemistry and then compared it to flow cytometry and compared it to PAR. And what they found was, when they looked at the percent agreement between flow cytometry and immunohistochemistry, it was almost 95%. So those two were very comparable. If we looked at PAR and immunohistochemistry, it was only 70%. So clearly what it tells us is there is a pattern to it. Immunohistochemistry is probably first, but again, the challenges with it are cost, the time, the morbidity, etc., followed by flow cytometry, which is what the vast majority of oncologists use. And probably right along there, or maybe just a hair behind, would be immunocytochemistry, and then PAR is much farther. Because again, PAR is often used inappropriately. It is more of a do you have cancer test, not necessarily do you have B cell or T cell. So it's not meant to be that. So again, in your practice, I would get into the habit of phenotyping your lymphomas. There's no reason this has to be done only by the oncologist. This can be done in your clinic. And to me, I'm excited when my primary care veterinarians do it, because I already have the information I can talk to the owner about, and then I'm able to provide them with everything that day instead of having to piecemeal some of the prognostic factors as those tests come in. So the other rationale for the phenotyping is in regards to treatment. We've certainly learned that some drugs do better for B cell, some drugs do better for T cell. So most oncologists now, the vast majority of us, are actually modifying our protocols. So it's no longer a one-size-fits-all chop that goes to B or goes to T. We're actually changing things around. The challenge is every oncologist does it a little bit different. We're using certain drugs for B and certain drugs for T. So to me, that makes the test very valuable because, one, it plays a role in the prognosis of the patient, and two, it plays a role in how we're treating them therapeutically. My protocol is tailored based upon whether it is a B or T. So once we have done this and we've gotten our diagnosis, the next step is in regards to treatment. We all know this is not a surgical cancer. The best way I always explain lymphoma to owners is that it's a liquid cancer. Liquid cancers are treated medically. And of course, we're talking about the use of chemotherapy. It's one of the biggest discussions that I have to have with every owner because they're all familiar with chemotherapy in people. The way I try to describe it is the dose intensity is not the same, maybe along the lines of a third less. So as a result, the side effect profile is vastly different. Versus people where we're all the way at the ceiling, in dogs it's much less than that. And most owners feel that they do not see a demonstrable change in their quality of life. Now that doesn't mean side effects don't occur. I usually tend to say 10 to 20%, but that's not zero. The reason side effects occur goes back to what chemotherapy does. It kills growing cells. So what we're trying to do is certainly kill the cancer cells. Most cells in our body don't grow, but some do, and that's where side effects come in. Hair loss in animals, certainly in big dogs, we see very little. Small dogs, we can see it. Effects on the bone marrow, white blood cells, may occur with certain drugs, but again, the risk of it dropping low enough to cause significant issues, in my experience, is only about 4%. And the final cells that are always growing are cells that line our gastrointestinal tract. So GI signs are certainly possible, but generally if we're giving a drug we think has a probability or a potential to cause GI side effects, we're all very proactive to start anti-nausea meds as a way to prevent this from happening. So our goal with chemotherapy is we're trying to get them into a complete response. We call that remission. We're trying to get all of the nodes normal during the time period that we're treating them, and usually during our first cycle, which is one time through the drugs. And it's usually going to be about 4 or 5 weeks long, depending upon the protocol the oncologist chooses. So for our traditional CHOP-based protocols, they usually involve L-asparaginase, L-SPAR, vincristine, Cytoxan, doxorubicin, and prednisone. And there are many different types of protocols that are out there. We used to treat dogs for 2 years straight, then it got cut down to 1 year, then 6 months, then 19 weeks, and now we go as low as 15 weeks. The protocol that's chosen is very much based upon the oncologist, the clinician treating, and what their familiarity with and what they feel most comfortable with. The good news is that generally somewhere between 70 to 90% of patients will go in remission. The average remission duration is about 7 to 9 months, and we tend to say the average survival is about a year. If a patient has all good indicators coming in, generally their average survival is probably about a year and a half. So to me, that's where it's important understanding running those tests in staging. I run the tests that I know may affect prognosis or the ones that may affect how I treat them therapeutically. So traditionally, after we finish the protocol, that's where we traditionally just monitor them. It depends upon the oncologist, but oftentimes it'll be once a month or once every 6 weeks they may come in. We know that the average dog at some point is going to relapse. What we do at that point depends upon several things. The first is certainly the owner and the pet. How is the dog feeling? Meaning if the dog is super ill, it's going to be hard for me to tell that owner, hey, let's move on to something else, versus if the dog feels fine. It also depends upon when. If we just finished CHOP and it's a month later and the lymphoma is back, well, that's a bad sign. And it means that it's going to be very difficult to try to get another remission in this patient, versus if we're a year later and it's finally coming back. So most oncologists tend to use, it's an unspoken 2-month rule. If they are in remission for greater than 2 months post stopping the original protocol, we may go back and restart the original. Some of us, like myself, I modify it the second time around. Other cases, if it's shorter than that, meaning it's a month later, well, we're not going to go back to those drugs because it was already starting to beat those drugs. We may move to something brand new. So we may look at either L-SPAR, CCNU, MOP, or rabifosfidine. There are multiple drugs that we have and multiple rescue protocols we can look at. And our goal with the second is to get them back into remission again and try to keep them in the second remission for as long as we possibly can. So kind of looking at our summary for lymphoma, some things to consider. Again, these cases are going to be coming to see you first. Get into the habit of doing your own cytology, looking at it, what to look for. Do all the cells look similar? Do you have artifact? Things like that. And then start comparing your evaluating the slide versus what the clinical pathologist comes back with. Get into the habit of doing the staging. Again, oftentimes it's difficult to get in with the oncologist, especially during COVID. Many of the staging diagnostics, they can be done in your practice. Routine blood work is a very easy thing to have done. And now you know what some of the prognostic factors are. And the phenotyping is certainly something you can be doing. That is not a specialist test. This can be done by the primary care clinician. Keep in mind what are considered prognostic factors. That way, when you're talking to the owner and you're going through the blood work results, you can say, hey, we saw this, the calcium's high. We know for a fact that may be a tougher indicator. Or maybe that makes me want to take chest x-rays to see if there's a mediastinal mass. In regards to the immunophenotyping, understand the tests that are out there. Flow cytometry is probably the easiest one and the one that's most commonly utilized. I would get into the habit of checking with whatever lab you use, where does the flow go to? How do I get this set up? And start doing it in your cases and sending it off. Again, it's going to provide the oncologist more information if you're referring, Or if you're the one treating, you're going to want to have this information. And now you understand why we do what we do, meaning immunophenotype is important for prognosis, and it's also important for therapy because we modify our protocols based upon it. In regards to treating with CHOP, certainly that is a topic entirely in and of itself, but many of us now modify our protocols based upon whether it's B or T, and then it gives you a little bit of an indication as to what we do when they relapse. So keep those in mind, and thank you very much.